about the aorta in the abdominal part and its branches, and then the second part will be in vascular about the inferior vena cava. And inferior vena cava and abdominal aorta are the main vascular structures localized in retroperitoneum. But we add also the system of veins which is supplying the liver and the outflow of gastrointestinal tract. So abdominal aorta is entering the abdominal space in the opening which is called hiatus aorticus. The aortic hiatus is a hole in the diaphragm which is localized at a level about TH12. And then the aorta is divided into two main branches at the level of L4, and this bifurcation is called bifurcation of the aorta, and it's an important landmark where we start the space which is called also pelvic region. So then aorta is divided into common iliac arteries, so common iliac arteries, and they are divided into the internal iliac artery and external. So those ways through the external iliac arteries are to the lower limb. So those arteries are not supplying directly the abdominal or the retroperitoneal or pelvic organs. The last part of the aorta is a arteria which is called caudal aorta, and this caudal aorta is called in human aorta caudalis. This vessel is then going down in the excavation of the sacral bone, and it is a remnant of the tail of the vertebrates who have tail, like also, for example, cat, or it could be also fish. So this is the same artery, but in human it is a very small and not too much important. So impaired arteries. The aorta has branches, and those branches could be divided in three groups. Two of them are called visceral because they are supplying the organs. So visceral impaired arteries are those which are supplying the original gastrointestinal tract and those organs which are during the ontogenesis developing from primitive gut. So this is a celiac trunk, superior mesenteric artery, and inferior mesenteric artery. They are impaired, so they are only one, and they are arising from the anterior aspect of the aorta. And here we have those. So this is a celiac trunk, superior mesenteric artery, and inferior mesenteric artery. The celiac trunk is dividing in three main arteries, which are called common, hepatic, left gastric, and lienal artery, those, or splenic artery. Those are supplying the upper part of the abdominal organs, including liver, including stomach, duodenum, including pancreas and spleen. The middle third of the intra-abdominal gastrointestinal tube is supplied by mesenteric superior artery or superior mesenteric artery. This artery is supplying small bowel and large bowel up to splenic flexure. So this artery is then dividing into the jejunal and ileal branches, ilocolic artery, right colic artery, and middle colic artery. Middle colic artery supplying the colon transversum. So up to colon transversum, the superior mesenteric artery is the main artery supplying gut. The last part, so also the part which is supplied in superior mesenteric artery is called also in embryology midgut. And the pathologies, where are they? They are typical for midgut. So they are some tumors, they are some inflammatory diseases. The hindgut is supplied by the inferior mesenteric artery, which is arising around in L3 vertebra, and is supplying descending colon, sigmoid, and rectum. So the last part of the tube, and is supplying the part of the colon up to the part which is covered by peritoneum, because the rectum has, we had lecture, that it has part which is localized intraperitoneally, and the second part is extraperitoneally localized in the pelvis, and the surface of the rectum then is called not peritoneum or serosa, but is called adventitia. So this is surrounding with the loose connective tissue in the pelvis. So the part of the rectum which is covered by serosa is supplied by inferior mesenteric artery. About celiac trunk. Celiac trunk and the division of it. Celiac trunk is divided into three main arteries, three large stems. It is the common division of those two, but the way how the truncus is divided is very variable. So we have a not common schema. The general which is seen here is about 60% of all cases, but in 30 about, or probably 25% of all, the supply of the abdominal organs could be a little bit different, because there is a very large variability in the segmentation of those arteries. So the main arteries are, this is a celiac trunk, and this is a left gastric artery, this is a splenic artery or lienal artery, and this is a common hepatic artery. Common hepatic artery is a common trunk which is then divided into important two main stems, gastroduodenal and proper. The proper, which is seen here, this is a proper hepatic artery, is supplying then the bile ducts, gallbladder, and also liver. And the gastroduodenal artery then is supplying a part of the stomach, duodenum, and also part of pancreas. The gastroduodenal artery is this, gastroduodenal artery. Gastroduodenal artery is important in cases of the bleeding from the gastroduodenal ulcers, because ulcers are quite common, even in developed countries, even in undeveloped countries. We had, I think, 3 weeks ago, a severe bleeding, and we had here very important role to occlude the bleeding artery. So the gastroduodenal artery is then splitted into the part which is supplying the greater curvature, and the ring which is here developed is called gastroomental. So this is gastroomental artery. The gastroomental artery is right and left, and the right one, or right part, is supplied from gastroduodenal artery, the left one from splenic artery. So you can see here that we have here rings which are filled from both sides. So this is very important, because we could have some situation when some vessel is occluded due to some pathological process like thrombosis, embolization, or in surgery, the surgeon could perform the ligature, closure of the artery after resection of a part of the organs, resection of part of the stomach, pancreas, etc., etc. And those rings are important in situations when is broken one arm of it, and the second arm could supply from the second side the organ. So then some surgical procedures are more or less prone to be ischemic for the organs. Pancreatic arteries, again, one interesting and important thing. Pancreas is an organ which is localized in retroperitoneum is covered by peritoneum on the anterior side and facing the space which is called omental bursa. This part of pancreas is, we can see it here. Pancreas has a complicated vascular supply because it's developing from two parts. Originally, one part is a ventral. The ventral part is then going dorsally, and we see it dorsally in adult. And the ventral part is more ventral in a part of the tail and body, and more dorsal is more ventral in body and tail, and also is more ventral in the head. So the pancreatic arteries are from lienal artery. Lienal artery is supplying the pancreas, and its pancreatic vessels are short pancreatic vessels, and also important posterior pancreatic artery. Then we have something which is called also pancreatic arcade. And this pancreatic arcade are two systems which are connected between gastroduodenal artery and superior mesenteric artery. This gastroduodenal artery is divided into the anterior superior pancreaticoduodenal artery and the same dorsal or posterior, and two branches are going also from mesenteric artery. This is a very important system which could help to supply liver or vice versa small and part of large bowel in situations when some artery is occluded. If it is a truncus celiacus or superior mesenteric artery, this is an arcade which is supplying the rest of the organs. This pancreatic arcade is also important in situations when the surgeon has to resect the pancreatic cancer. Pancreatic cancer is very frequently localized in the head, and only resection is a curable way of treatment, curing way of treatment. So then, surgeon could sacrifice sometimes the gastroduodenal artery, and also it could sacrifice also the proximal part of hepatic artery when we see here a sufficient supply on CT angiography, and we then help the surgeon to plan a surgery. So mesenteric, superior mesenteric artery, it's very easy to understand. We have a pancreatic vessels, but then we have those arteries which are from like a circle from right to left. So there's a media colic artery which is supplying the colon transversum, which is not seen here. Then colica dextra, right colic artery ascending colon. Then ileocecal, which is supplying ileum, distal part, cecum, part of ascendens, and appendix. And then we have a jejunal and ileal branches which are supplying here jejunum and here ileum. And we know from previous lectures that these arteries are different. The arcades are only two in a jejunum and three and more in ileum. And the vessels which are called recti are longer in jejunums, shorter in ileum. So mesenteric, superior mesenteric artery is easy to understand how it is supplying those structures of gut. Very similarly, it could be in inferior mesenterial artery, which is supplying the part of a bowel which was commented. So this is this part, and the inferior mesenteric artery is the artery which has branches. Left colic artery, sigmoidal arteries, which could be multiple, and superior rectal artery. Those three arteries supplying this part of the bowel. Then, it's very important that those two arteries are connected together. We know that mesenteric artery and celiac artery or celiac trunk are connected via gastroduodenal artery and those branches or arcades along pancreatic head. And here we have a very similar way. This way is in the region of a splenic flexure, where is the anastomosis, which is called, according to the author, rheolon. And this rheolon anastomosis is a way how the blood is able to flow between those two arteries. This collateral circulation is important in situations when one of those arteries is occluded. It will be occluded, one, due to some stenosis, thrombosis, dissection, etc., but we also could sacrifice the inferior mesenteric artery in situations when the patient has aneurysm. Aneurysm of the abdominal aorta could looks like here. And the aneurysm, here we have a renal arteries, and here we have celiac, mesenteric, and here inferior mesenteric artery. And this situation is very dangerous because the rupture of the aneurysm could lead to severe bleeding, and about half of patients is not able to be transmitted into the hospital alive. So this is very important that surgeon could perform here surgery, which is called implantation of a graft, or we, through the intra-arterial system in interventional radiology, performing stent graft placement. And in this stent graft placement, or graft in a surgeon with prosthesis, we perform new tube which is leading blood and protecting to rupture the aneurysm. And what is happening here? The inferior mesenteric artery is then occluded. So then the blood is not flowing into the bowel from this vessel, and the blood is flowing through this, typically through superior mesenteric artery, and is able to supply all the large bowel without any problems in normal situations when the other two branches, celiac trunk and superior mesenteric artery, are sufficient. When they could be closed or stenosed, then it could occur the situation which is called also abdominal angina, because the patient, after eating, feels pain in the abdomen, could have diarrhea, and the situation with postprandial pain is called abdominal angina. It's very similar to chest angina. So the angina, which is angina pectoralis, so it's very similar to angina abdominalis, the cause and the principle to feel pain. So then we have paired arteries. Paired arteries, paired visceral, are supplying the organs which are originally developing in the retroperitoneum, and they are typically part of a urogenital tract, and then adrenal glands. Those are arising from aorta from lateral aspects, and they are suprarenal arteries, renal, and gonadal, which are different in male and female because one is ovarian, the second is testicular. Those arteries are rising relatively high, the renal arteries and adrenal arteries at the level of those organs, but the gonadal arteries are rising here at a level about L2 or L3, and then they are going down into the pelvis in female or into the scrotum in male. Now we pay attention to renal arteries. Renal artery is a very important vessel because it's supplying the kidney, and the kidney is never-lasting working gland to produce urine. And then the organization of the vessels here is a little bit special. This is ending artery. What is ending? If you remember from the general anatomy, this is the way how the branches are organized, that they have no anastomosis in periphery. So it means when we occlude one branch, the whole segment, which is supplied by this branch, is then ischemic, not surviving. This is different than in the abdomen. In the abdomen, those three territories are common. They could be, they are connected, and they could provide perfusion, sufficient perfusion to the other parts. In kidney, it is not. So we can distinguish so-called interlobar arteries. Those interlobar arteries are separating so-called lobes, but in kidneys we very frequently don't talk about lobes, more segments. Then here we have some artery which is making this bow, and this is artery which is called arcuate. And from arcuate they are going small arteries which are called interlobular. So interlobar and interlobular. And those interlobular bearing on their branches glomeruli. So they are supplying those arterial structures which are producing prime urine. In renal artery is important also the zone which is called avascular. This avascular zone is localized in the region of kidney which is localized dorsolaterally. So the kidney has the axis which is not in a frontal plane, it is a little bit declined, and when you perform the axis through the kidney like this, or this is anterior, so anterior is posterior, the zone which is dorsolaterally has very rare vessels. And then this zone is very important for interventional procedure, which could be done by surgeon, urologist, or interventional radiologist, and we can insert catheter inside the kidney to has the access to the whole system and to derive the urine when the ureter is somewhere obstructed. And we protect then the function of the kidney. So this is important because there is a space where we have a less risk of bleeding. Renal arteries are also very, very variable because kidney is in the initial phase made from many segments. When they are fused together, sometimes vessels are remaining, not fusing together. This is about 13%, and here about 10%, the pathologies 7 and 5. But in general, you can see here that minimally 30–40% of all kidneys have no one but multiple arteries. Why it's important? When you can imagine that here is a space where is inferior vena cava, anteriorly from the renal vascular band. So then, when a surgeon is performing surgery nowadays, 10, 15 years, with laparoscopic or a robotic approach, without opening the space, with open surgery, or completely open surgery. So then the surgeon is seeing only those vessels which are seen here or here. So every time you can see multiple arteries, and they have to ligate those arteries to prevent bleeding during surgery, for example, renal tumor. What could happen when the surgeon doesn't know that here is a polar artery? The artery could be disrupted during surgery without control of the ligature. And then, because the artery in the initial phase is not bleeding due to spasm, this is protecting the bleeding during the period of the surgery on a surgical or at the surgical theater, then the bleeding could be delayed 12, 10, 5, 24 hours, and the bleeding could be seen in a patient with delay period. So this is very important to know that the renal arteries are very, very variable, more variable than truncus celiacus and mesenteric artery. So this is very important for planning of surgery. Ureter. Ureter, vice versa to renal parenchyma, ureter is supplied by many, many arteries. Renal, testicular, directly from aorta, from lumbar, from pelvic arteries, from internal iliac artery or branches of it. And on every stage, we have a plexus which is connected together. So then it's very important that is important situation. When a surgeon has to ligate those arteries, there is no risk of ischemia because the communication between territories is supplying the rest of the ureter. So this is important. Suprarenal glands and suprarenal vessels. Adrenal glands or suprarenal glands are glands which are localized in the renal fascia in the same space like kidney, and those are supplied by the 3 arteries and only 1 vein. So 3 arteries are those which are, one is superior, and it is from this artery which is phrenic inferior artery. The phrenic inferior artery is a branch supplying the diaphragm, and from which the small vessel supplying adrenal glands. The second one is directly arising from the aorta. This is a middle suprarenal artery, and the third one is typically arising from a renal artery. So it's a branch. They also, those arteries, could supply the capsula of the kidney. So then, also those are playing a role in the supply of the kidney, but not of the parenchyma, but capsula. Fibrous capsula could be also infiltrated by the tumor, and then those arteries are source of so-called parasitic vascular supply of the tumor. So then also those arteries are important to be ligated during surgeries. The more simple situation is in venous outflow. Venous outflow is through the one vein only. One vein only on the right side is directly into the inferior vena cava. On the left side is going into the renal vein. So then the situation in adrenal glands is a little bit different, but if you remember it from lecture, the adrenal gland has several zones, 3 zones of a cortex, and then 1 zone which is medulla. And typically the blood is flowing through all those vessels, through all those zones, and outflow is from medulla. And the medulla then is only one organ which is then drained into the vein. So the cortex and the vessels are organized, then the blood is flowing through this column of 3 layers in cortex, flowing into the medulla, and from medulla the blood is collected into the adrenal or suprarenal vein. Parietal vessels. Parietal vessels supplying the muscles and parietal, peritoneum, and subcutaneous fatty tissue, and also cutaneous coverage. And they are phrenic, inferior arteries, which are supplying phrenic, so diaphragm. Then they are lumbar arteries, which are supplying muscles. Lumbar arteries are typically 4. And then we have a iliolumbal artery supplying the edge between os ilium and abdominal wall. And the rest is a sacral median artery, which is known for us now. Pelvic arteries. This is something which the system should be for you important to understand how the other systems are working in the pelvis. So the pelvic organs are supplied by internal iliac artery. So they are dorsal and ventral. So here, those 2 arteries are going dorsally and the other are going anteriorly, like in this image. So then this is superior and here is inferior gluteal artery. Those are supplying gluteal muscles and also nerves, which are going this way. And these 2 arteries are going through the suprapiriform and infrapiriform foramen. So those are dorsal. The ventral are more interesting for us because they are supplying the pelvic organs. So they are arising in those order. And in this order, this is a umbilical artery, then it is umbilical. Then next one is obturator artery. The third one is uterine artery. And then the arteries which are supplying also rectum, rectal artery, but it is a medial. And the last artery is pudendal internal artery. Those arteries are supplying those organs which are localized in a pelvic region. Internal pudendal artery then is going into the pudendal channel, canalis pudendalis alcoci, with pudendal nerve. And this is a way how are supplied the organs or the muscles of the perineum. Perineal muscles, including the stripped sphincters of rectum and urethra. So this is a way how they are supplied by arterial blood and also by the nervous system. So motor here, somatomotor innervation. We had here also the information about the testicular and ovarian. The testicular way is through the inguinal channel into the scrotum. The same way is the way of the vascular band, and then you will see that the same way is the way of the lymphatic and neural supply of the testis. Testis only, itself testis, not the other structures. The ovarian way is a little bit different, and the ovarian way is into the pelvic region, and then look at the organization of the vascular band along the ureter. Ureter here is crossing iliac artery, and in male it is a different. Here is a crossing only ureter. The vessels are going along iliac arteries and veins, and then they are associated with ductus deferens in the entrance, inner entrance of the iliac inguinal channel. This situation is important because in a gynecological situations like resection of ovary or some other resections in the pelvic region made by gynecologists could occur situations when is injured or ligated the ureter. So then ureter has a very, very close relationship to gynecological surgeries, because sometimes it is very, very hidden. When you can imagine that those tissues are filled by this fatty tissue, and the fatty tissue could surround the vascular system. So then sometimes the resections are complicated. So there is a way of those structures which is prone to be problem for surgeries. So this is only some review, and the review here is combining the vessels, arteries and veins. And arteries and veins, here is some difference between it. The difference between vessels, between arteries and veins is in the organization of a plexus. Because even in a vesica urinary bladder, even around the rectum, even around the prostate, or in women in the region of the uterus, like here, those plexus are very important. Those venous plexus could be enlarged, especially in women after pregnancy, because the enlarged uterus could compress the inferior vena cava and outflow from the pelvis. Then it be the cause of the varices around the uterus, and they then could be a very important source of bleeding. For example, in situation of a caesarean section, because those plexus could be very, very thick, dense, and when you can imagine that the uterus should be dissected during delivery of the fetus, so then this transection of those vessels could be sometimes a source of important bleeding in the abdominal cavity. About the uteral blood supply. Blood supply of uterus is from two sources. One is from uterine artery. From uterine artery, those vessels are going into the uterus from the pelvic vessels, but on the edge of the uterus, there is a communication, natural communication between territory of uterine artery and ovaric artery. The ovaric artery is then connected at the edge or at the horn, the region of the horn of the uterus. And the superior part of the uterus is mainly supplied by ovarian, the inferior by the uterine. And from uterine artery is then descending the artery which is called vaginal. So this tube, genital tube, has organized by both margins, left and right, the anastomotic blood supply, even if it is arterial, even if it is venous. Then you can imagine the situation when we have compressed iliac veins here by the uterus. It could be, and you will see it, that we have here a mechanism how the arteries could compress those vessels. So then those plexus are then enlarged, and the outflow from the whole internal genitalia is via ovaric vein. Then is important, and on the left side it's entering the renal vein, and the renal vein is the way of the drainage of the blood flow, venous blood flow from the pelvis, from the left part of the pelvis in many situations. Next organ, and very important to understand the supply, is the rectum. Rectum is supplied by 3 territories. One territory is superior rectal artery. This is a view from dorsal. This artery is supplying this part of rectum. I have said that it is covered by peritoneal surface. The middle part is typically supplied from middle rectal artery, and the rest is typically supplied from internal pudendal artery. And here is a seen Alcock channel. This Alcock channel is a way of blood supply and nervous supply of those structures which are seen here. They are external sphincters, which are stripped sphincters. The same situation seen here with vessels, with veins. Those veins are making a plexus around the rectum, and outflow is one way into the inferior mesenteric vein, the second way is internal iliac vein, and the third vein is also going the same way, but around the Alcock channel again. Rectal veins are very important also in the situation when we have increased pressure in portal venous system. Portal vein is a vein draining blood, or the blood is flowing out from the intestine into the portal vein, and from portal vein into the liver. This is separated from the caval system, which is called systemic. Inferior vena cava has outflow from media and inferior rectal vein, and here we have 2 plexuses. One is external, one is internal, and those plexuses are dilated in situations when they are developed so-called portocaval anastomosis. These portocaval anastomoses are very frequently seen in patients with cirrhosis or other liver diseases, but also you can see them also in situations when there's increased pressure in pelvic veins, which are part of the systemic. Because I have said that women during pregnancy, they have varices around the uterus, but also those systems are connected together, and the high pressure in venous system has impact into the dilatation of rectal venous plexuses. So this is also important. So then also the insufficiency of venous system in standing positions, standing like me, who is here standing now the 5th or 4th hour. So then this hydrostatic pressure could have also important role in the development of a hemorrhoidal varices. And hemorrhoidal varices could be source of bleeding, source of inflammation, and a source of problems of the patient. Very frequent problems in a human population. So I have said that we have a systemic and portal venous system in the abdomen and pelvis. The systemic part is drained by inferior vena cava, and inferior vena cava, you know, that is entering right atrium, is going through the hiatus, and it is localized in tendinous center of the diaphragm. And inferior vena cava takes veins, liver veins, 3, 2 renal veins, iliac, commune arteries, and it is starting in the fusion or confluence of those 2 main large veins. But in this image, you can see very important situation. Common iliac artery on the right side is pressing on the left common iliac vein. This is called also nutcracker symptom or syndrome, because it is a like nutcracker compressing the vein, and the vein then has increased pressure here or decreased flow, and when you have decreased flow, you can hear clot formation. It could be the reason why on the left side we more frequently could see deep venous thrombosis. So it's very important. Also, very frequently you have a more developed varices on the left side than on the right side, because here is also this mechanism of a compression. Then we have a retroperitoneal veins, other than inferior vena cava. Inferior vena cava is connected with lumbal veins, but lumbal veins are veins which are transversally going into the middle part of dorsal retroperitoneum. But here is a very important web which has horizontal communications, horizontal bridges, and those bridges are bridging inferior vena cava and this artery, which is a vein, which is called ascending lumbar vein or vena lumbalis ascendens. And this web is organized, then is able to drain every step in different direction. It's due to the original segmental organization of the embryo, and the embryo has multiple veins which are leading the blood from the organs from caudal to cranial part. So then those bridges are important because there are alternative ways of blood flow when you have occluded inferior vena cava, or when you have occluded superior vena cava. The blood flow then could be this way and could supply the inferior vena cava. So this is the way of cavo-caval anastomosis. So cavo-caval anastomosis are connections between superior and inferior vena cava territory, and in some situations when one of those veins are occluded by the tumor, by the thrombosis, by the ligature, so then the blood could flow the other way and could provide the outflow from head or upper part of the trunk into the lower or vice versa. So, lumbar system is localized around the spine. And here we have one interesting schema which is showing the relationship between the caval system and portal system. Portal system is localized in the abdomen on the transversal section in the hepatoduodenal ligament, and in hepatoduodenal ligament you can see it with proper hepatic artery and a bile duct. In this image we have virtually dilated the spaces of peritoneal cavity, but in reality they are close together. They are lying one on the other. So there is no space, typically no space. They are very close, inferior vena cava and porta vein. But porta vein is localized ventrally from the anterior spec of the inferior vena cava. So inferior vena cava and renal veins and also veins of the intestine. So inferior vena cava have a main inflows at the level of the abdomen, renal veins, left and right. And porta vein is localized anteriorly, and this porta vein is constituted from two veins which have confluence at a level of about above renal veins, at the level above renal veins. And they are lienal vein or splenic vein, and here superior mesenteric vein. Those are two sources, two radices, two roots of a porta vein. And those veins then also take other blood from other systems. So the original situation is like this. So this is typical way of branching. So this is a lienal vein, inferior mesenteric vein, and superior mesenteric vein. Inferior mesenteric vein typically flows into the splenic vein. But then we know that we have some arterial ring around, or rings around the stomach. One is localized at the site of the smaller or lesser curvature, the second is on the greater, and those rings, gastric and gastroduodenal and gastromental, those rings are also inflowing into the portal vein. The portal vein itself has only one inflow, and this inflow is gastric right vein. So the portal venous system is taking blood from all gastrointestinal tract, including those glands which are developing there. So it's a pancreas and also the lymphatic organ spleen. This schema is showing those rings. You can see one ring, second ring, third, and in reality, fourth rings. Also, those communications are important, but those communications are important more in the situations when here in the liver we have high pressure. The high pressure could be due to cirrhosis or other diseases of the liver, that the blood is not able to pass according to the high pressure and other problems. It could be also thrombosis. And then blood is escaping and flowing vice versa, or this way from bowel. And here we have some localizations where are natural communications with the other systems. One is here, and the second is here. One is at the interface between stomach and esophagus, and the second is in the rectal region, in the anal channel. So those are natural communications with the other systems, which is caval, inferior vena cava, rectum, and superior vena cava, esophagus. Those rings then could help to escape the blood, and here you can see this communication, which is the most important. This is in the esophageal region and in pharynx and cardia of the stomach. Here are developed in patients with increased pressure in portal system, in vein, in portal vein, and portal venous system, collaterals which are called portocaval anastomoses. Those portocaval anastomoses are here in esophagus, in hemorrhoidal plexus, and also because of a high pressure is reopened this vein, which is called umbilical vein. The umbilical vein then is draining the blood into the region of umbilicus, and in the umbilical region we could see something which is called caput medusae. Did you heard about it? You know what is head of Medusa. It's of, you don't know, the Greek legends, where Theseus decapitated Medusa, which has instead the hair, the snakes. So it looks like those enlarged veins are arising from the region of the umbilicus, like the star-like or Medusa-like, and when they are tortuous like a snake, so then it is called caput medusae. So this is a very important outflow of blood from the liver. And for us, when we see the patient with portal problems, portal venous hypertension, This is very important. When we see it, this is a real direct sign that the patient has high pressure in portal system. Then esophageal and hemorrhoidal plexuses could be also enlarged, but here those plexuses called varices. So esophageal varices are very important source of bleeding in those patients with very developed portal hypertension. It could be due to alcohol abuse and cirrhosis, but it could be due to some hematological problems. It could be due to some autoimmune diseases. It could be due to tumors. And then those bleedings are very, very severe and could cause the death of the patient because they could exsanguinate the patient, or the blood, which is then going into the GIT, could be cause of some hyperkalemia or other metabolical problems. Now we turn to lymphatics. Lymphatics. Remember one important thing, lymphatics are arranged along vessels, and they are very frequently arranged along venous system, but they have many, many bridges, and they could have connections to the other regions. This is an example how the tumor of the uterus. This is a carcinoma of endometrium, and here on PET-CT with FDG, you can see here metastasis, multiple metastasis in lymph nodes. So we have to understand how the organs are drained by lymph nodes to see the metastasis and to estimate where metastasis could be and when they are, and then we have very important tool how to decide if the treatment of the tumor is possible or where should be done the lymphadenectomy during surgery, etc., etc. It's very easy to understand to it because when you have remembered the organization of blood flow, then you can see the lymph nodes. Typically, the blood flow copy of venous outflow, so because this is the same way, the same direction. So this is a ventricular. We have two rings again, and those lymph nodes are then drained, or lymph nodes could be affected. One lymph node, second lymph node, third lymph node, or groups of lymph nodes. This is a typical way. So then, when we have a tumor, which is localized somewhere here, we could have observed the way of dissemination of the tumor along the greater curvature. Then you can see that the next step is in a suprapyloric, and then it's directly to the celiac trunk. So when anybody asks you where you can see lymph nodes of the gastric cancer, when you remember this, it could be along the greater curvature, smaller curvature, in a hilum of a spleen, then in a pyloric region, and the second step could be then, or next step could be in around celiac trunk. But you can observe here also the connection here with hepatoduodenal ligament. When you can imagine that lymph vessels and veins have a very similar structure according to the valves, and those valves are well working only in a situation when the original size of the vessel is present. When it's dilated, the valve is not sufficient, and the flow of the blood or the flow of the lymph could be a reversal. So then you can observe also that the metastasis from gastric cancer could be observed at the hepatoduodenal ligament. So this is a principle of reversal metastasing, because when you can imagine that the tumor is obstructing the way of lymph flow, so then the flow of lymph could try to find a different way. In the pancreas biliary system, in the pancreas and biliary system, the lymph nodes are organized at two regions. I have said to you that the pancreas is supplied at the head region by the superior mesenteric artery and a gastroduodenal artery. So then we have two outflows. One outflow is along the superior mesenteric artery. The second is in the region of gastroduodenal, so in the pyloric region. And the third part is along splenic artery. But then you can observe that also the biliary tract has the same drainage like the stomach, the same drainage like pancreas, and all those could be seen that the region of metastasing then is in the region of lymph nodes along celiac trunk, and from a celiac trunk we have a ways dorsally along the aorta. So then, for example, when we have the tumors of biliary tract, so those, when tumor is somewhere here in a biliary gallbladder or in a duct, so then we can observe that the lymph nodes could be seen along the aorta or inferior vena cava. In intestinal, it's I think, extremely simple. Lymph nodes are following the vessels. The bridging is only where they are general anastomosis between those territories. So it's a very, very simple. Now we turn to retroperitoneal lymph nodes. So retroperitoneal lymph nodes, we have a right and left. From the left, the situation is a little bit easier because we have internal, external lymph nodes. External lymph nodes are draining the lymph from the lower limb, the internal from pelvic region, and then the flow of lymph and the metastasing could be along the iliac and then aligned around the left and anterior aspect of the aorta. From a right side, it is a more complicated because we have one line is along the margin, right margin of cava. Then the second one is in the middle between cava and aorta. And the third one is then able to pass to the left side. So then it is not impossible that you have a metastasis which is originating from the process which is on the right side of the pelvis, or probably somewhere at the limb, and the lymph drainage is crossing the midline, and we can see the metastasis on the other side. So it's possible. So those names are here. We distinguish paracaval. They are named right paracaval. Then we have interaortocaval. Those are those which are called paraaortal dextri. All right. Then we have anterior aortic, which are at the anterior aspect, and the left paraaortal, which are left. So here is very important structure. This structure, not too large, is called cisterna chyli. What is cisterna chyli? The blood from intestine is taking the substances which are absorbed, and they are transmitted to the liver when they are able to be absorbed into the blood. When they are taken into the lymph, so they are large molecules, lipoid molecules, making chylomicra, and those are taken by the lymphatic system, and here are sites where are connected lymph ways from intestine to the cisterna chyli, and from cisterna chyli through the hiatus aorticus, the duct, which is called thoracic duct, and this is a main lymph vessel, is taken lymph and then is going into the angle, which is called right venous angle, and it is an angle between superior vena cava, inferior internal jugular vein and subclavian vein. So this angle, which is at the neck, this is internal jugular vein, and here is subclavian vein, and the duct is going this way, and here the lymph is going into the bloodstream. Here, organization of the lymph drainage from the pelvic region. So here, remember the way of blood supply of a testicular. So from testis, we have typically the way of dissemination of the tumors not connected to the pelvic region. Typically, it is making metastasis at the region below renal arteries. So when we have a seminoma or embryonal carcinoma of the testes, quite frequent tumors, now quite very well treated or treatable. So metastases, they are not in groin, not in the pelvis, but localized in upper part of retroperitoneum. So we have to do CT, for example, here in this region to exclude metastasis. In women, it is more complicated because in women is everything more complicated. The drainage, according to the anastomosis between ovarian artery and uteral artery, or veins also, so then the drainage is more complicated. On next images, which are nicely published in TIMA Atlas, here are typical ways of metastasizing of a typical tumor. So from testis, this way. I have said to the region of renal arteries, or below them. From prostate to the pelvis. And you cannot see here any inguinal region. So those organs are not metastasizing to the inguinal. Difference in women. In women from external organs, typically it is in a groin, in inguinal region. But in vagina, uterus, typically in uterus, you can see only when we have a tumor in a region of a uteral horn, we can see metastasis in inguinal region. Why? Because into the inguinal region, we have one important structure. There is instead a ductus deferens in male, ligamentum teres. So rounded ligament is anchored in the groin region. So this is the way where the lymphatics are going the same way. So then, this is the reason why we have groin metastasis. And then it's depending on the level of when the tumor is. So in women, we can see metastasis everywhere, typically. Tributary regions of pelvis are important also for tumors which are in urinary outflow tract. Urinary outflow tract now, it is a quite increasing incidence of a vesica urinaria, so urinary bladder carcinoma. It's due to some other causes, but one of them is smoking, even is declining, so smoking and drinking of hard drinks is a predisposition to it. And from vesica urinaria, typically we could have metastasis in several regions. And also because the urinary outflow system is consisting of ureters, and along ureters there are multiple vessels, so then the outflow of lymph is also on multiple stages. So, lymph nodes. The last 15 minutes about nervi. This is quite very complicated. Here I would like to tell you about the basic principle of the nervous supply of the abdominal organs. So you can see here those yellow structures. We have very important organization. Then it is a localization is a side by side with the vertebral column. This is a sympathetic trunk. And the sympathetic trunk consists of multiple ganglia. They are called paravertebral. And then we have a system which is in the middle, copying the system of unpaired vessels, arteries, which is called prevertebral, or also preaortic ganglia. Those preaortic ganglia then are at the level of celiac trunk, at the level of the superior and inferior mesenteric arteries. So then ganglia are named after those vessels. And then we have a small two others which are called aortorenalia. Aortorenal, taky aortorenal bodies. At the abdominal and pelvic organs, we have two systems of motor innervation. Both are visceromotor, so autonomous. One is a parasympathicus and one is sympathicus. Parasympathicus is made by the 10th nerve and then sacral. And the division is at the region of borderline between midgut and hindgut, at the level of lienal flexure. The sympatheticus is arising from typical thoracic and lumbar region, and here is the schema of the lateral horns, where are neurons, motor neurons, visceromotor neurons for sympatheticus, and they are going through the anterior root and going through the ramus communicans into the sympathetic ganglion, which is localized in the sympathetic trunk, and through it, one could be relayed, the second is not relayed, the second could be relayed in the second ganglion, which is called prevertebral ganglion. So paravertebral are sympathetics, and prevertebral are also sympathetics, but they are in the midline. And when you look at this schema, there is a very important and interesting thing, that the sensoric viscerosensoric nerve has here the body in the spinal ganglion at the dorsal root of the spinal nerve, and then it's relayed in dorsal horn, and then relayed to the sensation of the pain. Then, when you remember that the way of sensitive nerve is the same like sympathetics, then you can remember zones where we can feel a pain from the abdominal organs, and this is a projection into the abdominal wall. About the organization of the nerves at the organs, they are copying the curves of the vessels, again the same. I don't think that it's important to know those singular nerves, but when you look at this schemata, please think about the segments of the spinal cord. They are about TH8 and more. About TH and surroundings, they are going through the major splanchnic nerve, which is a band of fibers, is going to the celiac ganglion, and celiac ganglion is a ganglion which is providing and relaying the neurons to 4 gut organs: stomach, duodenum, liver, pancreas, gallways, spleen. So this is a celiac ganglion. Celiac ganglion is providing, again, the same supply like superior mesenteric artery. Yeah? Head zones, or zones of head. This is a name. This is not head, my head, the name of the doctor. Here you can see where we can feel the pain from the inner organs. The most typical is that the biliary system you can feel pain on the right side in the Murphy symptom here in hypochondrium, but also on the same side on the right arm or right shoulder. The most interesting and important is pancreas. Pancreas and pancreatic tumors and acute pancreatitis. Acute pancreatitis is a shocking paining disease, and the pain typically could be felt at the level above the umbilicus. On the other side, the tumors of pancreas typically are growing into the celiac ganglion, and then you can feel the pancreatic pain. You can see that the patient is feeling the pancreatic pain at the back, typically. The reason is because I have here the images where the sympathetics is aligned with the sensoric. For the midgut, again, we have ganglion, which is called superior mesenteric ganglion. From sympatheticus are constituted splanchnic nerves. Probably you have remembered we have a cardiac nerves, superior, medial, inferior cardiac nerve. They are sympathetics. Also here the name nerve means that this is a way of distribution of a sympatheticus. We have a major, minor, and least. They are supplying from superior mesenteric ganglion the gut in territory of superior mesenteric artery. The inferior mesenteric ganglion then is supplying the territory of inferior mesenteric artery. We don't forget for the parasympatheticus. The parasympatheticus use the same ways, use the same ganglia. But here is one different thing. There is not relay. Here are those postganglionic fibers which are originally relayed in the region of the neck. So, this is important that we have the same ways for nerves, same organization, different relay, and then we can feel the body pain in the region of dermatomes, which have the same segmental numbers in the spinal cord, because you can feel it even like in a myocardial infarction on the ulnar edge of the arm, forearm, and minimus. The same way, the same principle is to feel the back pain in the pancreas, and you will see that also it is in the genitourinary system. The organization itself is very similar, like vessels, not too much interesting because it's the same. Remember, please, that we have also in the bowel wall 3 layers of plexuses, of nervous plexuses. One is submucosus, the second is mesentericus. This is between the layers of the muscle. And the last one is on the surface or below the serosa, on the surface of the bowel. So this subserose is a typical the way how the patient is feeling the pain in the peritonitis. For example, when the patient has acute appendicitis or perforated abdominal organ, typically peptic ulcer. Pelvic. If you remember the way how are distributed the sympathicus and parasympathicus in the bowel, you can also remember that kidney is supplied by renal ganglia or aortico renal ganglia, which are surrounding renal artery. Different thing is in distal part of urinary system. The part of the urinary system which is developing, associating with the hindgut. So then the supply is partially from the sympathicus, from the lumbar sympathicus, from first and second, and then those lumbar splanchnic nerves are providing the nerves to the inferior mesenteric ganglion, and then is supplied part of vesica urinaria and the prostate, etc. But the parasympathicus is from segments S2 to S4. So from sacral parasympathicus. Sacral parasympathicus then is also important for uterus and male organs. Prostate, seminal vesicles. This is very complicated really, but I would like to say you that important is to understand to the system. This is not the matter of the examination to know all those relays, but the system should be for you very important, because you then, in neurology, will know when you have, for example, transection of the lumbar spine, and when you, lumbar spine is somewhere here, when you have a parasympathicus impaired, so what is happening with the urinary bladder, etc. And it was all. This lecture was shorter because we have a before Christmas. And thank you for your attention.